A broken spine should never be the first real treatment plan. I saw three osteoporosis cases today, and all three cases taught the same painful lesson. Waiting can cost people their bones, and the biggest danger in osteoporosis is not just weak bones, but is delayed treatment, stop treatment, and missed treatment. Hello, everybody. I'm Dr. PK, and today I saw three osteoporosis patients this morning. Honestly, they reminded me of something very important. Osteoporosis is not a wait and watch disease once fracture starts happening. And the lessons from these cases are something every patient, every family member, and frankly, every clinician should remember. Lesson number one, a spine fracture is already a major warning sign. My first patient was 86-year-old man. He already had a thoracic compression fracture at T9, T12, going back to 2023. This was his second visit because of his thoracic pain, and I had ordered repeat thoracic spine and lumbar spine x-ray. Now a newer lumbar spine x-ray from March 4, 2026 shows new moderate compression fracture of L2, L3, and L4. Think about that. This means the disease was not just present, it was progressing. A vertebral compression fracture in an older adult is not a minor x-ray finding. It is often a fragility fracture. Patient is hunchback using walker, and he wants to get better, he wants to get independent, he wants to get back to his life. Major osteoporotic guidelines emphasize that patient at high risk fracture should receive medication to reduce future vertebral and hip fracture. In this case, he was diagnosed in 2023. No further workup was done. Patient was not offered any treatment. That's a bad medicine. So when one fracture happens, the next fracture is often already on the way. So the first lesson is simple. Do not normalize compression fracture in elderly. A fracture is not just pain. A fracture is a message. Lesson number two. Starting treatment is important, but staying on treatment is just as important. My second patient is an 84-year-old woman who is very opinionated, had osteoporosis and prior compression fracture. She had been on Prolia, but she stopped it on her own about a year ago because of fear and misinformation. That's a serious problem. There are lots of misinformation on internet, and people are fearful about the good medicine. Now, of course, medicine has side effects, but what's doing any benefit for you or not? That's the most important question. And when there's a serious problem like osteoporotic fracture, because denosumab, Prolia, should not be delayed or stopped, and this lady did on her own without a follow-up, without any anti-resorptive treatment plan. The Endocrine Society states that Prolia should never be stopped without subsequent therapy plan, because stopping it can cause rebound bone turnover, rapid bone loss, and increased fracture risk. Other bone health guidance warns that stopping denosumab or Prolia injection, multiple fractures can occur, and sometimes as early as 7 months after the last dose, especially in people who already had vertebral fracture. The second lesson is this. So I ordered DEXA scan and X-ray again on her, and most likely she will start her treatment. She agreed to. So second lesson is this. Patients should never stop Prolia casually, not because they are tired of injection, not because of a rumor, not because of a friend scared them. If Prolia must be stopped, there needs to be a transition strategy. Usually another anti-resorptive medication planned by treating physician. Stopping osteoporosis treatment the wrong way can be more dangerous than never understanding the disease in the first place. It's a wrong step. Lesson number three, the sickest, frailest patients are often the ones most undertreated. My third patient is an 80-year-old female with a history of Alzheimer's, and she's hunchback, uses walker. This is her first visit to me. She sees some other doctor in my group. So she had this old imaging showing thoracic 12 through L1 compression fracture. Her DEXA shows severe osteoporosis. Spine T score is minus 3.6, femoral neck minus 3.9, total hip is minus 4.1. She's hunched over, which is a walker, and also have Alzheimer's. It's exactly the kind of patient many people mistakenly leave untreated because they think she's too old, it's too late, or she already has frailty. That is backward. There are often the patients at highest fracture risk, and fracture in this age group can lead to pain, immobility, loss of independence, hospitalization, and even increased mortality. And Bone Health Organization note that medication like denosumab reduce fracture in the spine, hip, and other bones, and they are used in both women and men at high risk of fracture. Third lesson is frailty is not a reason to ignore osteoporosis. Frailty is the reason to take it even more seriously. So, what are the big take-home lessons from today's? Here they are. Number one, a vertebral compression fracture is a major osteoporosis event, not just an aging change. Number two, high-risk patients need timely treatment. Waiting can mean more fracture, more pain, more disability. Number three, prolia should never be stopped without a plan. The rebound risk is real. Number four, families need education because fear and misinformation can undo good treatment. Number five, in very elderly patient, the goal is not just bone density, the goal is preventing the next fracture, preserving mobility, and protecting independence. So yes, today's clinic taught me a powerful lesson. Osteoporosis is often undertreated, interrupted, and ignored until damage is already severe, and this has to change. If you or your loved ones had a spine fracture, hip fracture, very low bone density, please do not treat that as just old age. Ask what treatment plan is, ask how next fracture will be prevented, and if you're on prolia, never stop it without speaking to your doctor first. I'm Dr. PK. Take care of your bones and take care of your health, and don't ignore osteoporosis. Thank you for watching. Ask any questions. Thank you.